Hello and welcome to the video. This will be a lecture on transient ischemic attacks, or as we commonly call it, TIA, followed by me covering questions pertaining to TIA from the popular 1700 questions book. So let's start with the definition of TIA. As the name explicitly states, it is transient in nature. By transient we mean that it is temporary. And as the name also contains the word attack, we can safely deduce that it is an acute event. A TIA is sometimes referred to as a mini stroke, which means that it is a focal neurological deficit caused due to ischemia. By definition, a TIA should not last more than 24 hours, but they are usually only a few minutes in duration, less than an hour in most cases. The key here is full recovery after the attack. In most cases, this is caused by an emboli getting stuck and blocking the blood flow to a particular part of the brain. So if the symptoms resolve completely, why are we concerned about TIAs? It is because 10.5% of the patients who experience a TIA have a stroke within the next 3 months. Out of these, half occur within the next 48 hours of a TIA, so this is like a ticking time bomb. Also, a point to note is that about 15% of first strokes that one experiences are preceded by a TIA, once again emphasizing that it is a warning sign not only for a pending stroke, but sometimes also a warning sign for a pending myocardial infarct. Now to the signs and symptoms of TIA. As we just mentioned, all these signs and symptoms should resolve completely within the first 24 hours. These attacks, just like strokes, manifest symptoms restricted to a particular arterial territory, which makes sense because if an embolus is causing these symptoms, which would present with deficits due to insufficient blood flow to an area of the brain supplied by that particular vessel. So thinking of the pathophysiology, that makes sense. These attacks can be singular or multiple attacks can occur at the same time. Characteristic repeated multiple attacks are referred to as crescendo TIA. These indicate a critical stenosis in the superior division of the MCA, rare but happens. Another presentation of the TIA can be the amaurosis forceps or retinal artery occlusion, in which the patient feels like suddenly a curtain is falling over their eyes. This is painless, but if we do a fundoscopy, fundoscopic exam would show, as shown in the picture on the slide here, a pale retinal optic disc due to lack of blood supply. As the symptoms are caused by a localized occlusion, general and global symptoms such as vertigo, syncope, and dizziness are not a common presentation of TIA. When it comes to causes of TIA, there are three main causes. The most common cause being atherothromboembolism, which originates from atherosclerotic carotid arteries, and this is the most common cause. We can confirm this with the ultrasound Doppler of the carotids. It may present with the carotid bruit, but it is not always the case, and it is not very sensitive. Then we have cardioembolism. This is usually seen post-MI, but patient might have an embolus originating from mural thrombus. Also seen in patients, older patients who have AFib, patients with valvular diseases or prosthetic valves, also predispose them to make thrombi that can then embolize to the brain. The third relatively less common cause is hyperviscosity. So anything that causes your blood to get more thick, it prones the blood to coagulate and get stuck, causing blockage to the blood flow to a particular area, hence leading to a transient ischemic attack or a stroke. So anything that causes hyperviscosity of your blood, such as polycythemia vera, sickle cell anemia, myelomas, or any leukemias, can cause this. Rarely, TIAs can be a result of vasculitis or vascular disease. But classically, it is the etiology is not caused. We don't call a vasculitis a TIA, rather it's just a neurological complication of a vasculitis. Now to the clues to the causes of a TIA. So seeing the pathophysiology of TIA, we know that a blood flow to a particular area of the brain is blocked temporarily. Two major things can cause this, either a thrombus or an embolus. So what are some of the causes which might help us figure out, what are some of the clues that might help us figure out which is which? So here we look at the symptoms. If the event is due to thrombosis, the symptoms are progressively worsening over hours as the thrombus forms and expands, whereas an embolic event usually occurs suddenly and the symptoms do not progress. Thrombosis patients have a history of previous TIAs. Uh, they also present usually during sleep, and the patient wakes up noticing deficit, whereas an embolic event usually occurs during the day when the patient's active and functioning, and suddenly they notice a deficit. We already know the factors that contribute to thrombosis formation, the classic factors for atherosclerosis, such as hyperlipidemia, hypertension, diabetes, arthritis, vasculitis, hypertension. Whereas for an embolic etiology, we think of problems with the heart or valvular diseases, such as atrial fibrillation, mitral stenosis, or regurg, and so on and so forth. In the differential, we have things that might cause or explain sudden neurological symptoms. So let's say hypoglycemia is a common one. If it is a young patient, we can consider migraines with aura to be the cause. If twitching and shaking of the limbs is present, we might be concerned and think of focal epilepsy. If we have retinal artery occlusion, we can consider retinal bleed. Some of the other less common diagnoses are malignant hypertension, multiple sclerosis, which is known for its sporadic neurological symptoms. Peripheral neuropathy can be one. As we know, no good differential is complete without a psychiatric diagnosis in it. So it could be that the symptoms experienced by the patient are somatic in nature. So that's there in the differential as well. So now we have a patient who comes in with symptoms that seem like a TIA. We just covered the differential, so we should run tests that help us narrow down the cause. First up, we do a CBC or full blood count, looking at things like platelet levels along with clotting profile, which would tell us about the PT, PTT, APTT, giving us an idea if this might be a thrombotic event. Other tests that give us a better picture are ESR, UNEs, blood glucose level to rule out hypoglycemia, lipid profile for the patient, the chest x-ray, ECG for our cardiac rhythm to check for things like AFib or any other abnormality. We discussed the most common cause of TIA as an embolus due to carotid artery stenosis. So a carotid Doppler ultrasound and an angio really helps us to know how bad the stenosis is. A CT or an MRI are also helpful. CT to see for a bleed, and MRI for any masses or neurological effects, such as seen in the case of multiple sclerosis. Finally, an echo is helpful too. As we talked about, there could be a neural thrombus post-MI or any valvular problem which can be visualized using the help of an echo. So that gives us a bit better picture of what is causing this attack. Assuming we have diagnosed TIA, now we have to treat the patient. As TIA is transient and the patient is supposed to recover fully, we treat them not for the TIA per se, but to prevent further episodes and possibly a stroke. So we try to first off to control the cardiovascular risk factors in the patient. Here we try to control the blood pressure, trying to keep it lower than 140 over 85, lower lipid levels if high, manage diabetes better, and try to get patients to quit smoking if they are currently smoking. So all these can be used by medication and lifestyle changes. Um, then there is the antiplatelet therapy. Just as we do with stroke patients, we start an individual on aspirin 300 milligrams once a day for 2 weeks initially. Then we switch to clopidogrel 75 milligrams once a day, which needs to be continued. If the patient cannot tolerate clopidogrel, we give them 75 milligrams aspirin with slow release dipyridamole once daily. If the patient is already on this regimen and has a stroke or a TIA, we add warfarin. Um, Warfarin is also given if the source of the embolus for the TIA is found to be cardiac in nature due to, let's say, valvular diseases. Finally, the most common cause of TIA, carotid stenosis. So if the stenosis is found to be over 70%, we should aim to do a carotid endarterectomy within 2 weeks of the TIA. It is important that we do not stop aspirin preoperatively. Remember, we just learned that initially we give for first 2 week aspirin 300 milligrams once daily after a TIA. So once we prepare a patient for a carotid endarterectomy, we do not stop this aspirin. While surgery is preferred over stenting as it has better mortality rates and the outcome of the surgery is much better than stenting. When it comes to prognosis and management of patient who presents with TIA, we have a handy tool known as the ABCD2 score to help us. The ABCD is a mnemonic for the score. So an A is for age over 60 years. We give them 1 point. If the blood pressure is over 140 over 90, the patient is given 1 more point. Then the C stands for clinical features. If there's unilateral weakness, then we give the patient 2 points. If there's speech disturbance but no weakness, we give them 1 point. Then comes the first D, which is for duration of symptoms. If the symptoms are longer than 1 hour, the patient gets 2 points, while if the symptoms last anything between 10 minutes to 59 minutes or less than an hour, we give them 1 point. Finally, the second D is for diabetes. So if the patient is diabetic, they get 1 more point added. So what does the score really mean and how does it help us? Well, it helps us predict and watch out for high-risk patients who might have a stroke in the next week. A score of 4 or more is thought to be high risk for an early stroke, so the patient must be admitted and seen by a specialist within the first 24 hours of the symptoms. Actually, anyone with a score of over 3 or more should be admitted to the hospital. A score of 6 or more suggests that there is an 8.1% chance of a stroke within 2 days and a 35.5% chance of a stroke within the next week. Other high-risk factors for a stroke after a TIA are the presence of atrial fibrillation, having more than 1 TIA in a week, or having a TIA while on anticoagulants like warfarin. So now on to the questions. Well, these questions are from the famous 1700 questions book circulating online. As the material is freely available on Facebook, it is safe to assume that these questions are not copyrighted, so we shall cover the ones pertaining to transient ischemic attacks here in this video today. The first question is question number 28, and it goes like this. A 65-year-old woman presents with transient arm and leg weakness as well as sudden loss of vision in the left eye. Her symptoms resolve within the next couple of hours. What is the most appropriate next intervention? Here we see that the event was transient and the patient recovered fully within a few hours. So this is most probably a TIA. Considering the patient's age and sudden onset of symptoms, we can safely deduce that this event was embolic in nature. What is the most common cause of embolism in causing TIA? We talked about it in the video earlier. It is carotid stenosis. So to investigate the flow through the carotids actually, the first thing we should do is a carotid Doppler ultrasound, making C the most likely answer over here. Well, the next question is question number 211, and it goes like, a 72-year-old man fell while shopping and hurt his knee. His vitals are fine, he speaks in a low voice and is very slow to give answers. What is the most probable diagnosis? Option A, Alzheimer's disease. Option B, vascular dementia. Option C, TIA, option D, pseudodementia, option E, Pick's dementia. So let's think about it. Here there are a few factors that point against TIA. We mentioned earlier that a TIA rarely has global symptoms such as syncope and a fall. And here we notice that after the episode, the patient had residual symptoms of low voice and he was slow to answer. Considering the patient's age and the history, the case is most likely of Alzheimer's disease. And the answer most probably here is A. Next is question number 263. A 60-year-old woman is found by her son. She was confused and had urinary incontinence. She has recovered fully after 6 hours with no neurological complaints. What is the most likely diagnosis? A. Stroke. B. Vestibular insufficiency. C. TIA. And D. Intracranial hemorrhage. Here we see a patient having an episode with neurological symptoms and then she completely recovers within few hours. This history goes best with TIA. A stroke would have had worsened, or at least the symptoms would have stayed. Here the symptoms have completely resolved. An intracranial hemorrhage would have presented with a headache. So the most likely answer over here is C. So the next question is 344. A 48-year-old man gets repeated attacks of loss of consciousness and TIA. What is the most likely cause for this? A. Atrial fibrillation. B. Mitral stenosis. C. Atrial stenosis. D. Hypertrophic obstructive cardiomyopathy. E. Carotid artery stenosis. This is a simple one where they're giving us the diagnosis. So basically it is asking us for the most common cause of TIA. So as we covered early in the video, the most common cause of TIA is carotid artery stenosis. So this makes E the most likely answer here. The next question is question number 434. A patient had a TIA which he recovered from. He has a history of stroke and exam shows a heart rate is sinus rhythm. He's already on aspirin 75 milligrams per day and an antihypertensive drug. What other actions should be taken? This is a management question. This patient has had a TIA and has also had a stroke in the past. Currently, the patient is on aspirin and an antihypertensive medication which we do not know of. When we talked about management and treatment of TIA earlier in this lecture, we mentioned that a patient should be on clopidogrel instead of aspirin. So here we will add clopidogrel along with, that is for sure. But along with that, we also talked about minimizing the cardiovascular risk factors. The patient is already on an antihypertensive, so we are bringing down the blood pressure. Another big risk factor we talked about was hyperlipidemia, so which can be brought down by adding a statin. So here we would add both clopidogrel and statin to the regimen. More of this will be covered in treatment and management of stroke when I cover that. So for the time being, here the most probable answer is D. Now we have question number 505. A man was brought to the emergency department from a shopping mall after collapsing there. He is conscious and answering questions now. His ECG shows irregular rhythm. Your choice of intervention: A. CT scan, B. MRI, C. 24-hour ECG or a Holter, and D. echocardiogram. Here the clue is in irregular rhythm. So when combined with the history of a sudden collapse, suggests a TIA, which can be due to an embolus originating from the heart. So an echo will give us a clearer picture, literally, of the heart, telling us if there's a valvular problem or a thrombus that could be originating from the heart itself. Hence the most probable answer here is D. The next question is question 722. A 72-year-old man has been on warfarin for 2 years because of past TIAs and strokes. What is the most likely complication the patient should be careful with? A. Headache. B. Osteoporosis. C. Ear infection, D. limb ischemia, E. diarrhea. This question is more for the side effects of warfarin than for stroke or TIA. When a patient is on anticoagulation therapy, there is a chance of intracranial bleed, which can present with a headache. It is an early warning sign of bleed, so one should definitely be looking out for any new onset of headaches when they're on warfarin, making the answer here A. The next question is question 933. A 3-year-old girl presents with complaints of sudden right facial weakness and numbness and pain around her ear. There are no other symptoms. What is the most likely diagnosis? A. Subarachnoid hemorrhage, B. Bell's palsy, C. Stroke, D. TIA, E. Subdural hemorrhage. We notice that the patient mentioned here is just 3 years old. Having a stroke or a TIA would be really unusual in this case, even though all of the conditions mentioned are also unlikely in a patient this young, unless some congenital disorder is present. Bell's palsy is perhaps sometimes seen in children, and the symptoms described here are pretty consistent with Bell's palsy or seventh nerve palsy, which has great prognosis in children, by the way. So the answer, just based on the symptoms presented, is B, Bell's palsy. Well, on to our last question, question number 1329. A 24-year-old woman presents with tingling and twitching of her fingers followed by a throbbing unilateral headache. What is the most likely diagnosis? The key word here is unilateral headache with tingling and twitching. That too in a young female. These symptoms are commonly seen in migraine with aura. So the aura is the tingling and twitching, and the unilateral headache is classical for migraine. And to top it off, they said young females, so very common in that age group. This makes the most probable answer to be B. Well, with that, I conclude the video. We have covered almost all questions pertaining to TIA from the 1700 questions book. We've also covered the diagnosis, treatment, and criteria for TIA. As usual, please leave your comments and feedback and let me know what are the topics you would like me to cover in the future. If you have any suggestions about how I should reach these topics or how I should make these videos, please let me know, and do subscribe to the channel. Thank you for making it to the end of the video.